Okay, so we will start. Good morning, everyone, and good evening for Prof. Sally Prasad. Thank you for attending today's guest lecture. I'm Dr. Ayuswan Dewi, the head of School of Public Health, Faculty of Medicine, Udayana University, will serve as your host today.
I'm not a host.
I'm sorry, why I hearing back the recording?
It's okay here, Dr. Hayu.
Okay. Ya. Om Swastiastu, Assalamualaikum warahmatullahi wabarakatuh, Shalom, nama budaya, salam sejahtera, salam kebajikan. Honorable Dean of Faculty of Medicine, Udayana University, Dr. Komang Januarte Pinati MKes, distinguished guest lecturer, Prof. Sally Prasad, and Vice Dean for Student Information and Cooperation Affairs, Prof. Adi Wirawan, who was the previous head of School of Public Health, Faculty of Medicine, Udayana University, who also initiated the collaboration with Prof. Prasad. I'd also like to welcome Head of Unit of Information and Cooperation Affairs, Dr. Citra Wulan, and Head of Department of Public Health and Preventive Medicine, Dr. Sawitri, and especially our beloved lecturer and student of the Faculty of Medicine and School of Public Health, Udayana University. It is a pleasure to welcome all of you this morning to our guest lecture, which is part of Udayana Medical and Health Guest Lecture Series 2021. This guest lecture series initiated by Unit of Information and Cooperation Affairs, Udayana Faculty of Medicine, and today's guest lecture is the second of the series, jointly held with School of Public Health, Faculty of Medicine, Udayana University. As we all went through the past 2 years, coping and adapting to the ongoing COVID-19 pandemic, we have witnessed the massive and entrenched impact of the disease to our life, our health system, and public health in general. The emerging of COVID-19 and its spread across the globe should make us realize the increasing need of understanding the concept of global health and global health security to be more prepared for similar situation in the future. We have seen the pandemic has made our health system in the brink of collapse, and our primary health system have also been affected with the delay of several essential health services. This situation should become a lesson learned for all of us, medical and public health professionals and also students, to better understand the capacity and our health and community system, and to improve our readiness and preparedness for better and timely mitigation. Our guest lecturer today is Professor Sally Prasad from University of Minnesota. He will talk about global health post-COVID-19 pandemic. To Prof. Prasad, thank you so much for providing your time to giving the lecture today, and hoping all of us can learn and enhance our understanding about global health and primary health, especially in the post-COVID-19 pandemic era. It is our honor to have you here, and I'm hoping that this is the beginning of more collaboration and more inspiring lecturers in the future. We will love to have you here in Bali when the pandemic is over. I'd like to pass our gratitude to Dr. Citra and her team from Unit of Information and Cooperation Affairs for her support. And also thank you to Angga and his team from School of Public Health Student Association to support the student arrangement to this meeting. I think I remembered reading about this pandemic, the Spanish flu, for instance, back then when I was a student. I thought that it will only be history. Never imagine coming across one in my lifetime. So I really hoping we will be better prepared if it happen again in the future. Thank you so much. And And now, without further ado, I will like to invite our Honorable Dean of Faculty of Medicine, Udayana University, to provide his opening remark and also to officially welcome and introduce Prof. Sally Prasad as visiting professor at School of Public Health, Faculty of Medicine, Udayana University. To Bapak Dekan, the time is yours.
Thank you, Dr. Ayuswan Dewi. Good morning, Om Swastiastu. Assalamualaikum warahmatullahi wabarakatuh. Salam, nama budaya, salam sejahtera untuk kita semua. Our distinguished guest, Professor Sally Prasad, MBBS, MPH. Welcome, Prof. Sally, to our guest lecture series. Who I respect, Dr. Ayuswan Dewi as the coordinator of School of Public Health, Medical Faculty, Udayana University. To my Vice Dean for Student Affairs, Professor Adi Wirawan. Head Department of Public Health, Dr. Ana Agung Sawitri. Head of Information and Cooperation Affairs, Dr. Citra and also Dr. Wiwi. And also to all participants of this guest lecture today. First of all, I would like to thank God for His blessing that allow all of us together in this in the morning to attend the Udayana Medical and Health Guest Lecture Series. This guest lecture series is organized by our Unit of Information and Cooperation Affairs, and for today, the host for the series is School of Public Health. The topic for today is global health in post-COVID-19 pandemic. As we all know already, the whole world now is facing the COVID-19 pandemic. This pandemic affects many aspects of our lives, including our health status. Therefore, we need a deeper understanding about this matter. Thus, we can plan or prepare a policy or strategies how to survive and improve in facing this pandemic, and also how we can prepare in facing similar or other problems in the future. So the topic will be discussed today is very interesting and also very important for us. Ladies and gentlemen, today is also a special day because through this guest lecture series, I would like also to introduce Professor Sally Prasad, MBBS, MPH, as the visiting professor at our institution, especially in School of Public Health, Faculty of Medicine, Udayana University. Professor Sally Prasad now is the Executive Director of Center for Global Health and Social Responsibility at the University of Minnesota, USA. On behalf of Faculty of Medicine, Udayana University, I would like to express our highest appreciation to Professor Sally Prasad. Experience of Professor Sally will be very beneficial to improve our capabilities of our staffs as well as our institution. In the future, I hope more and more collaborative activities can be conducted related to education, research, and also in other areas. I would like to thank Professor Sally for your kindness to be a part of our institution. Thank you, Professor Sally. Ladies and gentlemen, before I end this speech, I would like to at this now is a Friday on the 4th of December 2021. The Udayana Medical and Health Guest Lecture Series in the topic of global health post-COVID-19 pandemic officially open. Thank you and good luck for all of us. Thank you, Dr. Ayu.
Pak Dekan, Mr. Dean, for your remark and also for welcoming our visiting professor, Prof. Sally Prasad, to become part of our Udayana Faculty of Medicine family. And before we move to the next session, I think we should capture this special moment. And I hope everyone is getting ready with their best smile. And please, the committee, we will take documentation now before we move on to the next session. So Angga, please take the lead.
Okay, Doctor and ladies and gentlemen, I would to take over this guest lecture to take a documentation with a screenshot. So maybe you can prepare your best smile. So I will begin the documentation in 3, 2, 1, smile. Okay, for the next slide. On the next slide is of the camera. Maybe we start from the first slide again with another gesture maybe. In 3, 2, 1, say cheers.
Cheers.
Okay, thank you, Doc. I would give back to Dr. Ayu. Thank you, everyone.
Thank you, Angga. Thank you, everyone. I'm sure we have great photos, and without diminishing respect, Mr. Dean and other officials who have other agenda are welcome to leave the room. And again, thank you for your kind attendance. Thank you, Bapak Dekan.
Thank you, Dr. Ayu. Thank you, Professor Sally.
Thank you.
Yes, okay.
Terima kasih Pak Dekan.
Oke, mohon izin.
Terima kasih Pak Dekan.
Pak Dekan.
Mau lanjut Niki, nggih.
Thank
Silakan
you.
ya. Semoga
Nggih.
sukses
Ada.
semuanya. Oke, iya.
Sukses semua Pak Dekan.
Mohon izin, nggih.
Okay. Okay, I think we are ahead of schedule. That is great. So now is the main session that we have been waiting for, and the guest lecture will be moderated by my colleague, Dr. Sutarsa. And first, let me introduce and read his brief bio. Please share the screen. Okay, please wait a moment. I think this takes time. Next one, Angga. Okay, Dr. Sutarsa, his complete name is Nyoman Sutarsa, MD, MPH, PhD, and FHEA, quite long name. And his qualification, he's a Doctor of Medicine, graduated from Faculty of Medicine, Udayana University in 2009, and complete his Master of Public Health with major on health system and policy analysis at La Trobe University, Australia in 2013, and completed his PhD in medicine, health system and health policy at the Australian National University, Australia in 2021, and currently is a lecturer at our Department of Public Health and Preventive Medicine, Faculty of Medicine, Udayana University. But he is also the lecturer of Australian National University School of Medicine. And he's also a fellow of the Higher Education Academy. His expertise is quite a lot. He's majoring in health system, health policy, global health, rural health, and primary health, primary care. I think and many more. And Dr. Sutarsa, the time is yours.
Yep. Thank you very much, Dr. Ayu, for the kind introduction, and welcome, Prof. Sally. So it's always good to see familiar faces in this difficult situation or in this difficult time. And I would like also to thank the Communication and Collaboration Affair Unit at the Faculty of Medicine, Udayana University, for organizing this event. So hopefully we will have a series of inspiring lectures along the way. And also I would like to thank Dr. Firsa, which is the graphic designer for this particular event, and also all the students and colleagues from Faculty of Medicine, Udayana University in Bali. So as mentioned earlier by Dr. Ayu, so COVID-19 has exposed the fragility of the health system as well as our global health system. But also at the same time, the pandemic has proved or has tested the resilience of our community system across the world, in particular in Indonesia. Sadly, the pandemic also exposed the existing social and structural inequities across the globe, in particular developing countries, leading to inequitable effects of the pandemic across the society. And today, we are indeed very fortunate to have Prof. Sally with us to talk about the COVID-19 pandemic, the global health system and primary care, especially from a global perspective. Before we start the lecture, I would like to read or introduce more comprehensively our guest lecture today. So Prof. Sally Prasad, MD, MPH, is the Carlson Chair of Global Health and the Executive Director of the Center for Global Health and Social Responsibility at the University of Minnesota. He's also Professor and Vice Chair of Education at the Department of Family Medicine and Community Health at the University of Minnesota, Adjunct Professor at the School of Public Health, and Fellow at the Institute on the Environment at the University of Minnesota. He is also an honorary visiting professor at the University of Cape Town, South Africa, and also at the Faculty of Medicine, Udayana University, Indonesia. He has been inducted into the Academy of Excellence in the Scholarship of Education at the University of Minnesota. Prof. Sally is the co-director of the Rothenberger Leadership Academy, a cohort-based leadership training program at the University of Minnesota. He is also the co-lead of the CDC-funded National Resource Center for Refugees, Immigrants, and Migrants, and also the NIH Fogarty-funded Northern Pacific Global Health Consortium. He is also a founding member of the leadership team of Advocacy for Global Health Partnership. And on the other side, Prof. Sally also has worked in underserved areas, including rural areas, for more than 3 decades. As a clinician, he conducted health service research and has been engaged in education across disciplines. For the past 15 years, he has been part of the Rural Health Research Center at the University of Minnesota. He is actively involved in the growth of academic primary care and global health research training across various parts of Africa, India, Thailand, and South America, and hopefully soon will be in Indonesia as part of Family Medicine Global Education Network. He has also been involved in academic department strengthening and mentorship training across various universities. So I can go for much longer than that, but it will take a lot of our time. And without further ado, I would like to welcome Prof. Sally to the guest lecture. One more thing before we start, Prof. Sally. So it will be a free gift or merchandise directly shipped from Sydney for 3 of our best question or response today from the participants. So without further ado, I would like to hand it over to Prof. Sally. Please, Prof. Sally.
Thank you, Om Swastiastu.
Om
It's
Swastiastu.
indeed it's indeed a great pleasure to be here. I'd rather be in Denpasar right now. I'm talking to you from Minnesota. The temperature just dropped down to 0 degrees, and we're expecting some snow tomorrow. I'd rather be in the hot climes of Bali right now. Thank you, Dr. Ayu. My particular thanks to Dean Komang for taking the time to come to this session. I'd also like to thank two of your folks who have become good friends. One of them, I think she's in the audience there, Dr. Sri Budanti. We actually hosted her here, and she came to my house and we cooked for her. So I'm guessing, Sri, you're a good friend by now. And the other, Sri introduced me to Adi, and the rest, they say, is history. Thank you, Adi, for getting all this started. I do think that we are in a very critical point. We have to acknowledge that this pandemic has exposed things that we took for granted, and that we are in a particular stage where we have to think of the future in a new way. So with your permission, I have a presentation, and I'd like to go through the presentation. I'm happy to ditch the presentation and just go to questions, because I'm sure your extremely knowledgeable audience will have a really thought-provoking discussion today, particularly with what Dr. Sudarsha mentioned, that the gifts that you're giving. But if, with your permission, I'm going to start with the presentation, and feel free to interrupt me, stop me at any time, okay? All right. Don't adjust your screens. This is not the image of the world people see, right? Most often, there is an image that is skewed towards the north. I'm not just presenting this image today because I'm speaking to an audience from Bali. I do feel we need to start looking at what we do in the field of health, in the field of global health, with new lenses, new ways, and be humble enough to acknowledge that whatever we've done for the past many decades has not been good in building what Dr. Sudarsha mentioned, resiliency in communities. And this is a critical point for us to keep in mind as we talk about the future of global health. So today I'm hoping to talk a little bit about what this would mean. And I'm really thrilled, Dr. Sudarsha, I've had a good conversation with Adi about this. The importance of primary care, family medicine is my chosen field. Primary care in building health systems from the ground up. So I hope to spend some time talking about that too. So to begin with, we all come here with a passion. We come with a passion to be involved in the work that we're doing, involved in the lives of our patients, and to alleviate suffering if at all we could, right? However, we got to keep in mind that the passion that brings us here needs to be channeled in ways that is productive rather than self-serving. And I'm telling you this because, unfortunately, if you look at the field of global health in the past, probably couple of decades, it's been more about the passion driving self-interest, individuals' interest, rather than betterment of communities. The boring form of healthcare is to look from the ground up. And that, if anything, is my take-home message. The boring form of healthcare is the most important way of doing healthcare. So today I want to talk a little bit about an overview of what we call global health, which itself seems like a rather funny term, and we'll talk a little bit about that. The current situation of where we are, and the role of family medicine. And I'm using family medicine as a proxy here for primary care, and I'm willing to open that for discussion too. Let's start with this. What's the impact of COVID? COVID has exposed health systems across the world. I've heard of how it has affected Indonesia and Bali. I can tell you it's much worse here in the US. I still see patients in hospitals. We have significant stressors that our hospitals are overflowing, and there is an all-time high in terms of distrust of science, distrust of higher education, and distrust of the medical profession. So it's been a very unusual time. And you folks have probably heard of this, that we are going to see worsening situations, 1.4 million additional tuberculosis deaths by 2025. We know that before COVID, there was about 28 million multiple drug resistance tuberculosis patients in India alone. We don't know what that number is going to be now or in 5 years. HIV-related deaths. I think this is a conservative estimate that 673,000 additional HIV-related deaths in 2020 alone. Malaria, increased malaria, maternal and child health mortality. Numbers are going to keep coming for us for the next few years of how devastating the spillover effect of COVID. While our attention has been on COVID, what else has happened? But I want to give this as a contextual piece to poverty, the deepest global recession since World War II. Some are estimating in many economies, this might be about 25% worsening of the economy, 25% worsening. And this is critical because we know that when economic depression occurs, the health indicators start going down. Malnutrition increases, maternal deaths increase, childhood nutritional issues worsen significantly. And malnutrition itself, the effect of it can last maybe 3 generations or more. So we are yet to see the overall effects of the COVID pandemic. And I'm talking about this before Omicron. So I've come to a conclusion right now when I'm giving my presentation. I don't talk about a post-COVID world. I think we need to sincerely be addressing it as the COVID era. What COVID has not only created in its disease patterns, and we are still unraveling the full breadth of the conditions that SARS-CoV-2 can influence, but the spillover effect to individuals, populations, and health systems around the world. So I know you didn't call me here to give you a lot of doom and gloom. You know this story. This is not new. What I'd like to do, however, is to take a viewpoint that is from the global health viewpoint. And I like to approach this from a historical perspective. The term global health is relatively new. It's been around for probably about 3 decades. Prior to that, other terminologies were used: international medicine, international health. Prior to that, and there is a term that is still being used called tropical medicine, tropical diseases. It sort of seems rather funny when you think about it because diseases can be everywhere. I prefer to call the history of what now constitutes global health in eras. And in that vein, I'd like to introduce what is global health. There are many definitions. The one that I like the most is this by Copland and his team. It was published in The Lancet in 2009. And the 2 important terminologies that he used in this is critical for me. One is improving health. And the second is achieving health equity. I want us to ponder on that a little bit because we never in this definition talk about sickness. We talk about health. That's a very critical and important distinction. Because I can tell you where I am here in the US, we've been experts in sickness care. We are not good in healthcare. We're finding fantastic new technologies to take care of a lot of diseases, but we are not addressing health. So definitionally, we are way behind right now. The other point to keep in mind is this definition for me is very critical because it brings up a sense of being rights-based. Health equity is about rights-based approaches, about health being a universal good. It does acknowledge that there exist social inequities or power asymmetries. And also inherent in this, hidden in the text, is a premise of governance challenges. And that in global health is a huge concern right now. If you look at issues around vaccine inequity, it's by and by the most important product of inequities because of governance issues, either macro level global governance issues or the partnership between countries kind of issues. So let's take a step back. Global Health 1.0, a predominant part of the 19th century, is what I'd like to call Global Health 1.0. There are stories of smallpox vaccination inoculations being done in India. The smallpox inoculate was being transferred from from England those days, and then done in communities in India. A landmark event of the 19th century was what was called the International Sanitary Conference in 1851. That is the one that led to the current terminology around global health security. But the premise behind that is still not very good. It's like, keep the diseases out there, away from us. Not about let's tackle it together. It's about isolating people away from rich countries. This is also a time when tropical medicine was a big term. There's a statement from the French colonial army in Africa that a doctor is better than a battalion of soldiers in winning populations. So health was used as a way to conquer communities. It became an extension of colonialism. There was also a sense of adventure, a spirit of adventure. It was a time when you would go to a new place, discover an exotic new disease, like this gentleman. This is Lieutenant General Leishman of the British colonial army, who in India is credited to have discovered the organism that causes leishmaniasis. My concern is not that he did this. My concern is that it was named after him. Why don't we call it Kala-azariasis? The disease Kala-azar was known in the community for centuries before Lieutenant General Leishman discovered the organism. Is it appropriate to do that? Now, this is the spirit of what Global Health 1.0 was. A lot of adventure, a lot of going to new places. Then moving past Global Health 1.0 was Global Health 2.0. Predominantly in the 20th century, particularly after World War II. World War II, the aftermath of World War II, was a time when there was a high degree of solidarity and the growth of multilateral institutions, the UN, the WHO, UNICEF. I'm getting a lot of feedback. Are you folks getting that too?
Yes, let me check. I think some.
Ya, bagi yang peserta yang lain, tolong di mute ya ininya supaya tidak banyak background noise dan mengganggu proses perkuliahan dari Prof. Sally.
Ya, sudah.
Thank you, I appreciate that. So World War II was sort of one of those events that for some time brought the people together around the world with their vested interests. But there was a growth of what was called multilateralism. So the growth of the WHO, UN, etc., was because of that. There was also a term that came in there about international health and international medicine. And I'm quite critical of the term international medicine because it's an approach towards health and healthcare through the medicine-only aspect. And there's also the growth of mission hospital. What I mean by that was they were using healthcare as an approach towards proselytizing. Growth of Christianity in many parts of the world and other religions was part of that movement. Don't get me wrong, mission hospitals have done a fantastic amount of good work around the world. But when it's combined with religion, you sort of wonder, what is the primary purpose of delivering health and healthcare? Global Health 2.0 was also, like I mentioned, about medicine and thereby about biomedical reductionism rather than an integrated, holistic view of what health and healthcare could and should be. So that was also the era, Global Health 2.0 was also the era where there was a growth of what I like to call single disease approaches. You might ask, is this wrong? And again, none of this is wrong. This is just my observation. Single disease approaches, in some cases, have been extremely successful. Smallpox eradication is a classic example of that. Some not so. Malaria eradication program didn't work that well. Some of them are persistent. For example, in HIV, PEPFAR, the President Emergency Program for AIDS Relief, has been credited to bending the curve of the AIDS pandemic in Africa. Same thing with other diseases. There was an approach of Ebola or bust, HIV or bust, TB or bust. These vertical programs have been very important in the history of what we have done. The challenge, however, and this is a huge concern for me, if you go to places that have received funds from PEPFAR, you realize that it is a single disease approach. What I mean by that is the investment doesn't go beyond that individual disease. You're not talking about building resilience in the communities. So when a new entity comes in, forget a new entity. In places with high load of HIV, when you have other diarrheal diseases, which can be just as deadly as we know, there is not a flexibility in the community to approach that. So we're not talking about resilience in communities, we're talking about attacking individual diseases. My point here is that it's important to have this vertical approaches, single disease approaches, but they need to be on the foundational strength of public health and primary care. And so one of the important things for us to keep in mind is I'm proposing that this COVID era will launch us into Global Health 3.0. And the Global Health 3.0 needs to be based on a very strong foundation of public health and primary care, on which now you can place the single disease approaches. And very importantly, very, very importantly, we need to start really practicing the premise that we are here to learn from and with each other. That knowledge acquisition or the truth seeking in the field of health and healthcare is not the prerogative of a few important big name universities in some big countries. That every person has an equal opportunity to understand the complexity and equal responsibility to collaborate with others in tackling the very troublesome challenges we're going to face. Dr. Ayu mentioned the challenge of COVID-19, and yes, it is a huge challenge. But if you listen to some of our colleagues in environmental health or environmental sciences, they'll tell you COVID-19 was nothing. Just you wait till we start seeing the full effects of climate change. So we have more challenges coming our way. So until and otherwise we don't tackle it in a concerted way, we're going to be in trouble. So what is the current situation? Well, you know about this. This is where we are. COVID-19 has asked us stern questions. And prior to this presentation, I was chatting with Dr. Sutarsha. There is a growth of conspiracy theories around the world, in all parts of the world. And it's rampant here in the US too, where there is skepticism and distrust. And the COVID-19 pandemic is exposing a lot of that, including amongst healthcare providers. Now, as I'm sitting here in Minneapolis, Minnesota, a few miles from where my office is, this happened. I think you folks heard about this, right? George Floyd being murdered by a policeman. That was just a few miles from where my office is. And I'm not mentioning this as a way, as something that we are proud of. We are not. We shouldn't be. But it's sort of interesting because I was talking to one of my patients, an elderly Black gentleman, after this, and he told me something that was rather stark. He told me, Doc, it's now that you're getting to know, this has been happening for decades, for centuries. Our parents told us this. We tell our kids this. The inequities that led to George Floyd's murder has been in society. And here is the key thing. It's not just in Minneapolis. It's not just in the US. I'm originally from India. I've seen this in India. I've probably not paid enough attention to this. It's around the world. The premise of inequities being at the undercurrents of everything that we do. And by the way, this is there in the field of global health too. There is agenda setting by somebody sitting in some posh office somewhere else in the world and writing papers and deciding for countries and governments as to what should be done. So one of the predominant themes that is occurring in global health, which I'm really happy is happening right now, is a premise that we need to decolonize global health. What we mean by that is it's a process of deconstructing colonial ideologies. Not so much about power difference. Power difference is going to be present inherently in every place, every society that you can think of. But that power difference should not lead to superiority of one versus other, of one religion versus other, of one skin color versus other, of one thought process versus other. So the field of global health today demands, needs, and should very strongly embrace decolonizing. And if we do that, we'll be much better off in Global Health 3.0. So while Adi and Sri and the rest of you folks are very courteous in inviting me for my expertise, I am sincerely hoping that I'm here to learn from and with you. And hopefully my partnership with your university will continue to achieve that for a long time. I'm going to suggest that one important consideration that you have is to think about a holistic view of approaching from a primary care aspect. What I mean by that is if you look at what constitutes health, the improvement of health in a community, we think that clinical care at best contributes about 10%. At best, 10%. So what about the rest of it, the 90% of it? You folks have heard about the social determinants of health. Yes, right? It's in a lot of studies right now. In some ways, I'm not a big fan of the premise of social determinants of health, not that they don't exist, they absolutely do. I feel that just talking about the social determinants of health is a passive approach, because those social determinants of health exist because we as a society allow them to exist. So ultimately, we need to look at them as political determinants of health, because it's in the public policy arena, in the political arena, that those social determinants of health have been perpetuated over decades. So that is something very important to keep in mind. I'm going to stop sharing my screen for now. I do have a little more of the presentation. And I want to pause here, open it up for any questions before I go on to my next part.
Yap, silahkan teman-teman sekalian ya, adik-adik mahasiswa ya, kalau misalkan ingin bertanya dalam bahasa Indonesia silahkan, nanti saya akan bantu menerjemahkan. Yep, anyone that would like to raise issues, concern, questions, go ahead. I do have one, Prof. Sally.
Go ahead, please.
So, yeah, because we from your discussion around the history of global health, it's quite fascinating that global health actually promote the division of labor in practice as well as in knowledge creation. There is why now there is a growing appetite to decolonizing global health because of that. But the reality is that the power asymmetries between the global north and the global south will continue to exist and play significant role moving forward. Do you have any thoughts around how can we make this a bit more equal playing field across the players? And how can we promote epistemic justice at this moving forward within the global health arena?
Dr. Sudarsha, I didn't tell you that I have all the answers, right? No, so good. No. But here are some thoughts. You're absolutely right. we know history has been replete with examples where power structures are what determine agendas. So I'm not naive to that. I do think there are a few important considerations. One is there definitely is a movement in the global north about the importance of decolonizing. There definitely is. The second part, and I'm seeing this in the growth of the political power of what used to be called low and middle income countries, right? I grew up in India till my formative years. So India is a major player in the world arena right now. Maybe not to the extent of some of the high income countries, but the voice is definitely being heard. So I do feel that this premise of multilateralism that was there after World War II had been present and then got ditched along the way when ultranationalistic ideas came about, is finding some foothold again. So with that in mind, we need to acknowledge that there is a power in that multilateral approaches, right? The second point for me has been an intriguing observation that the World Trade Organization, the WTO, has much more power than the WHO, right? The WHO, unfortunately, has not done anything wrong. I don't think WHO has done anything wrong in the COVID-19 pandemic. But structurally, it's not been given the authority or the power to function like the WTO does. So I think in reimagining some of these large organizations, particularly the WHO, et cetera, I think we need to give the power that we have given the WTO to the WHO. And so the macro level governance, the interactions between the macro structures are very important to keep in mind. Today, global health, I like to look at it in two realms, right? Me currently living in a high income country, I have more in common with, say, Adi or Dr. Ayu than somebody living in a tough neighborhood in Minneapolis. And the person living in the tough neighborhood in Minneapolis, where my clinic is, has more in common to somebody living in the slums of Bombay, in Dharavi. And so this is the paradox. So we got to abandon the premise of high income, low income countries, but look at who are the ones who are not achieving equity within their own countries, within their own contexts. So I think the paradigm shifting in that ways will give us more tools to approach the question you asked about the power structures. And I do feel that ongoing engagement in this conversation, in the decolonizing conversation, is very critical. I like the high energy that is there in the literature right now. I'm concerned that whenever I see high energy, I'm worried about high burnout, that in 2 years' time, the premise of decolonizing will be an old language. That's my one concern in this.
Yeah, thank you, Prof. Sally. So on that note, so we actually have a question here from my guru, yeah, Prof. Niriana. So asking about how can we promote the equity in terms of access to healthcare in Indonesia? Perhaps you can't talk from Indonesian perspective, but you probably can talk from the US perspective or from India perspective or from a global perspective. So that one question, and I will read the next question for you, Prof. Sally.
Sure.
So do you want to respond that first?
Sure. Do you mind if I keep that question for a little later? Because I think when I do my presentation about the primary care, we'll have some answers there.
All right.
Okay.
Okay, we go with the second question. So we've got a question from Tarfi Aufia.
Okay.
So thank you, Prof, for the insightful information about decolonizing global health. But how we as students, as the next generation of public health, can do today in our current situation?
That's a wonderful question. In many ways, I feel that you folks are our future. So while I was talking about all the challenges that climate change is going to bring up, I'll probably be retired or maybe way past retirement at that time, if you look at the full extent. So it's going to be something that you folks will be facing much more emergently. I'm sorry we are leaving this a mess for you. I do feel that the voice you have in this is critical. There was a beautiful essay written by a doctor from Pakistan, Munira Rashid, in the BMJ not long ago about colonization occurs because we allow it to happen. And I was struck by that. I was struck by some of my behavior in my past of how I've let racial and other injustices occur to me and to people around me. So as students, one important thing to keep in mind is don't put yourself down. Put a lot of value in what you have and your thoughts. I do strongly believe that the premise of truth-seeking, creation of paradigms, which is inherently present in science, is the purview of everyone. So it doesn't have to be somebody from a big name US university who's producing those papers. It could be you. It should be you. That is the approach I would recommend. And I do strongly feel that in many ways, about for 10 years, we have become less interconnected compared to what we should have been. Part of it is political, ultranationalist politics from many countries. I do sincerely hope that your generation will take it up as that partnership that you do with your friend here in Udayana, with your friend in other universities in Indonesia and beyond, is something that will hold us together in this premise of learning from and with. I hope that answered your question.
I think you make it really clear, Prof, over there, and a few clear points for us moving forward, really. So to make sure that our voice is heard by the outside. But there is also an issue with that. So the more I read about the decolonizing literature, so most of that actually been written by prominent scholars from the global north, unfortunately. So, but yeah, we've got another question, Prof. Sally. So it's a lot of questions. So do you want to answer it now, or do you want to move with your presentation, Prof?
If you don't mind, I can move with the presentation, and hopefully some of the questions will be answered by that. But I'd love to come back to those questions again.
Yeah. That's probably a good idea, Prof. So we continue with your presentation, and then we can come back to the questions.
Perfect. And this part of my talk, I would like to talk a little more about the importance of primary care training. Dr. Sudarshan mentioned about what are the challenges in other parts of the world in terms of equity. And there was a question regarding that too. And hopefully I can convince you that primary care is going to be a critical part in that conversation of what should be the future of where we should be going. We know this. What we really need to do now is to find mechanisms like this person is trying to do to take an upper hand from the COVID virus, right? So I'm here to propose that primary care training is an important and integral part of this response, and it's an imperative. We have to do this in our health systems. So where have we been? Now, a quick overview. 3 phases in medical education. Before the 1900s, in most parts of the world, medical education was very disorganized. There have been medical schools, organized medical schools in quote-unquote Western medicine for centuries, but they were disorganized, so what you got from one place may not be the same as another. It was based on an apprenticeship model. You were attached to a senior doctor and learned whatever the doctor told you. There was a strong sense of a social contract. What I mean by that was society was allowing you to experiment on them, to learn on them as an investment in itself. And I like this premise, particularly in the field of medicine, is very strong. There were some attempts to standardization, did not occur. Now, moving past that, the next important stage was what we would call a standardization phase. In the US, this was on what's called the Flexner report that's getting a lot of press. This Flexner report was not the only report that led to standardization. There were others around the world too. But many countries borrowed from the Flexner report. And today around the world, you have a model that is more or less similar, where you have 2-year preclinical and 2-year clinical model. That is held for more than 100 years, pretty much in most medical schools around the world. After that, we've had a significant growth of specialization. And I'm strongly talking from the US context. I do have numbers from other parts of the world, but the specialization growth has become so much that today in the US, more than 90% of medical graduates get specialized, more than 90%. So primary care is the realm of about 10% or less, depending on the numbers you see. This is a huge concern. And why is it a concern? Well, there is a push towards practical training, but there is not that premise of a critical thinker. When I talk about primary care, I don't want you to look at it as, yeah, I went into primary care because I didn't get into, I don't know, cardiology, orthopedics, or some fancy term. I want you to think about primary care being the true integrator, the one that puts everything together, the one that holds everything together. This is what we need in what we would call the new students, right? We have a lot of experimentation going on with new pedagogical tools and models in medical education. It's an exciting time. Around the world, and Dr. Sudarsha, in Australia, you've heard of newer models of teaching. We talk about longitudinal integrated clerkships and game theory and newer ways of training our medical students. It's also putting a lot of demand for them. What is lost in this conversation is the premise of what is the meaning and purpose of a physician. And I'm here to say that you can find meaning and purpose in pretty much any discipline you do. But the premise of that from the context of providing towards communities is highest when there is growth of primary care. There was an essay that came out of Italy when Italy was being ravaged by COVID-19. And one part of the essay struck me. It said that Western countries have been designing a person-centric model of healthcare, where the disease demanded a community-centric approach. And that was the biggest failure we've had in tackling COVID-19. We are still person-centric, not community-centric. And the community, I would pose it here, is the world. We are not approaching the world, we're approaching our own corners. That individual versus collective is the essential difference between the specialization approach and the primary care approach. There's a whole lot of conversation about precision medicine, but we are not concentrating enough on the community good aspect of what we should be doing. And Dr. Ayu, you should acknowledge this. There's been a slow divergence of medicine and public health. What I mean by that is there is more of this specialization approach towards precision-based approaches towards sickness care, that we are forgetting basic public health, which is critical in advancing health and healthcare towards communities. So what is primary care? I can probably spend hours talking about this, but let me just condense it into these 4 C's. First, contact, continuity, comprehensive, and coordination of care at the grassroots level, across all ages, across all communities. I'd like to also propose a new C. The first 4 C's was described by a wonderful proponent of primary care called Dr. Barbara Starfield. And I appreciate what she's done. But I think one thing that was missing is the context part of it. We know today that in communities that have a pretty higher primary care penetration, the ravages of COVID has been less so, partly because of the flexibility aspect of what we're doing. And so the context-based approach, where we know that the future is going to be another disease, we don't know what it is, and also recognizing that other disease exists in the milieu of current diseases. So we don't forget the diabetes, hypertension, cardiovascular disease, tuberculosis, malaria, dengue, diarrheal diseases, mental health, maternal care, malnutrition, while our attention is captured by one disease. So that context-based approach is part of the rest of the C's that we would need. So what do we know of primary care? This statement probably summates all of it. Primary care is the only healthcare component where an increased supply is associated with better population health and more equitable outcomes. So this, Dr. Sudarsha answered that question that you talked about, right? How do we do better equity in the health and healthcare that we deliver? And I'm proposing that the foundational aspect of any healthcare system is based on very strong public health, very strong primary care. And the studies are there in various parts of the world that this is a critical part of it. We also know that the distribution ratio needs to be about 50% to 50%, 50% of primary care, 50% of all other specialties combined. How are we doing in the US? We are pathetic. We are really pathetic. My university is one of the top in the US to send people into family medicine. One of the top. Every year we get an award. We send about 17% of our graduates to family medicine. We should be doing much better. How are we doing? Well, varied. US is poor. We need to do much, 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 much more. Latin America, there is significant variation. In pockets, there are fantastic penetration of primary care, some that are growing. In Europe, there's some variation. Some countries have done much more. If you look at the numbers from some of the Scandinavian countries, some of the areas around like UK, Germany, others, the primary care index is higher. So we know that the quality of care is better, equity is better, and all quality metrics that you use for all diseases are better. And by the way, cost of care is better too. You know this, US cost of care, healthcare is one of the worst in the world. We just don't do enough for the money we spend into healthcare. So I am here to say that the strong imperative is to have more family medicine physician training. We need to emphasize the importance of context, where there is flexibility in the learning. One of the things that we talk about is the premise of uncertainty and the comfort with uncertainty. In training, we need to get our people to recognize that we're training you to recognize that there are more things coming your way. We need to be obviously attaching our teaching to strong One Health and planetary health principles. I know Udayana has a wonderful One Health coordinating center. That should be an integral part of every physician's training. And we need to make sure that we form the strong bridge between clinical care and public health. More public health, more adaptive learning, comfort with uncertainty. Look at primary care as an integrative approach. And deep inside, our learners will get to the why of all problems. So I hope I made my case that we need strong primary care across all health systems. I know Indonesia is interested in it. They've started some good ways. And I've had conversations with Adi about what are the best ways to get it started in Udayana. And I'd be happy to help develop that too.
Really provocating thoughts, Prof. Sally. And it's interesting because you mentioned that there is actually a divergence now between the medicine and public health, and this is also my observation in the medical curriculum. So the components of social health and also the component of public health and population health is being reduced structurally. So it's not just happened in one institution, but it's happened across the globe, because it's being prescribed by the medical council. And I think it's interesting that you mentioned that point. We're actually producing more doctors with biomedical orientation rather than community or public health orientation. So it's a structural issues, and I think we need structural change to make things better. But also there is also the length of the training, Prof. Shelley. So I observe in Australia, for example. So if you want to be a family physician or general practitioners, the length of the training is so long. So they start with the bachelor, and then they do medical training for another 4 years. And then they have to enter the GMO for 1 or 2 years. Then they will enter the primary care trainings. And there is also the trend in Indonesia now with the specialization in primary care. That's also quite worrying. So once you graduate as a medical doctors, you're no longer primary care practitioners. So I would like to see some of your thoughts around that, Prof. Sally, before we go through the question that we have on the chat.
That's a good point. I think there needs to be a better understanding of what is needed in a particular community. I'm using Malawi as an example, for example, that decided that they cannot afford to have physicians to do all primary care. But there are primary care physicians, family medicine physicians, who then use models around physician extenders to cover larger communities so that the integration occurs at the physician level. So, if you were to ask what is the executive function of a family physician, they do that integration beyond that individual aspect of it, right? Yeah. The length of training has been a question that has come up in various circles. I do feel that there are two main approaches to it. One is to not significantly differentiate what we in the US call undergraduate medical education or medical student education. Keep that the same, because you need to understand the values that one is not a lesser degree, right? In the US, there is a movement. There are a few medical schools that have started this where they do a 3-year medical degree. And I'm already hearing in the community, well, they're a little bit of a lesser doc because they don't get the training. And that's not productive for this conversation. However, in residency or postgraduate training, there needs to be that difference. There needs to be a difference, not so much from understanding it as a length of training, but from a competency-based training. So in other words, if Dr. Sudarsha, you're going to be a new family doc that is in charge of this district X, what are the training requirements that you need in a formal way? Say in the US, it's a traditional 3-year residency program. But then when you go to the district, can you have an ongoing learning model that we can build on? I'm involved with a very small experiment like that in India. And I'm keeping my fingers crossed that there is acceptance, but there is definitely acceptance amongst the participants. I don't know if the society is ready to accept that yet. That's something for us to see. But that is a critical part in recognizing that we don't devalue primary care. It shouldn't be considered a lesser of the thing.
Yeah.
Right? That's a critical part of it.
Yeah. Thank you, Prof. Sally. So we continue with some questions. So very simple but important question here, Prof. Sally. How to get equal distribution of vaccine for COVID-19 globally?
You asked a very simple question. I think you folks have heard about the COVAX model, right? Where people contribute. On paper, it was wonderful. In practice, it is not. And there are some tenets for us to learn from that. Number one, Dr. Ayu mentioned the global health security agenda. I think the global health security agenda has sometimes given us the wrong incentive of using global health as a way to deter people, not diseases. So the approach towards a vaccine conversation should have been, where are the hotspots? Can we do vaccinations there? And can we now do this quote unquote source control model? Granted, in respiratory illnesses, it's very difficult to achieve it, but there was no push towards that. From a political science viewpoint, I do strongly feel that this has been a remnant of the ultranationalist policies in various countries, including the US, of the previous administration and various parts of Europe, that have cornered the market and want to make sure that there is no political blowback.
Mm.
I'm not saying that we need to donate all supplies, because personally, I'm not a huge fan of charity-based approaches. But could we have done technology transfers? Could we have achieved the technology transfers and allow the resilience within communities to pick up? That would have been a better approach. This is where I think sheer overpowering capitalism fails in a political good. Don't get me wrong, there are parts of capitalism that I like, not all. When it's an overpowering capitalism that does not consider the greater good conversation, then we are in trouble. So the vaccine equity conversation is unfortunately caught up in this right now.
Yeah. Thank you, Prof. Sally. So I would like to invite Dr. Wiwi probably ask the question directly to Prof. Sally. Dr. Wiwi.
I must have put her to sleep. I'm good at that.
So yeah, I'll just go through the question, Prof. Sally. So what about the current strategy for the COVID-19 in the perspective of global health, especially for the Omicron case in several countries? So do we need that? Yeah, go ahead, Prof. Sally.
Yeah, Omicron is interesting. I'm keeping my fingers crossed to see how bad it is. I know the initial report being highly transmissible, but some of my people that I know from South Africa are saying that they're not seeing the same degree of lung injury with the Omicron. So I'm keeping my fingers crossed. This is purely speculation on my part. I don't think the final answer is here yet as to what Omicron is. The other part that is particularly interesting, the other part that is very critical here, Dr. Sudarsha, that the premise that Omicron originated in South Africa, I'm not sure that is true. I do think Omicron has been around in other places, and South Africa and Botswana are the places they were found. And we shouldn't penalize them. And if you look at some of the, again, approaches towards blocking travel, you're blocking few countries, but Omicron is already in the US. We have identified one here in Minnesota today. So it's already here. So blocking travel is not the approach for us. What we really need, and it's a trick that we missed, in the US for sure we missed, is approaching it from a rapid testing and quick isolation viewpoint. RT-PCRs take time. I know your lab has been spending a lot. I know the heroic efforts of your lab. I've heard how much time they spend in trying to, do the turnaround time. But we have not invested enough in rapid testing. And we know in an infection like COVID, getting a rapid testing going is critical. And then isolation based on that is what we would need. That's one trick that we miss. Are we going to learn from past experiences? I'm not very confident. I'm not very confident because I'm looking at the bans on travel and I'm like, that's not the true public health approach. We need to be doing more where we are. So,
yeah. Thank you, Prof. Sally. So I would like also to invite some students to directly ask the question to Prof. Sally. That's probably much more interactive. So, Lohvera Sridiantari, would you like to unmute yourself and ask the question directly to Prof. Sally?
Yes.
Yeah, go ahead, Lohvera.
Thank you very much for the time. I want to ask about how to increase the role of everyone to improve global health 3.0 and get the equal of health, especially to detect infectious disease. on COVID-19 in family and in a remote area. As we know, many people maybe choose not to inform their illness because of social judgment or because they don't have health insurance. Thank you.
That's a wonderful question. I think the first part of your question, how do we get people more involved in Global Health 3.0? Global Health 3.0 is not going to be a popular approach because there'll still be the approach from, what Dr. Sudarsha asked, the power structures, the big funding agencies of the world who would want to perpetuate the models that have continued, right? And because that's the way they think is the right approach. So convincing people to go beyond is partly to ask from a grassroots level up the question, what are you doing? Why are you doing? And how come you get to decide what you're doing? It shouldn't be some person writing a grant in Boston or Atlanta or London determining what happens in the villages of Bali, right? So asking those questions become important. The second point is, I'm not saying that people in London, Boston, and Atlanta are evil. Well, maybe not all of them. You can definitely find partners, but the partnership should be a true partnership. The agenda that is needed should be set in the local communities. I was involved in the creation of what's called the Brochure Declaration, and I'm glad to share that with you folks. In the Brochure Declaration, we have stressed the importance of bilateralism, of an equity-focused approach where there is true partnership, not somebody sitting in another country determining the agenda for Bali or Indonesia, right? That is going to be the true approach. The second part of your question, there is the importance of achieving equity. And we've talked about equity in a few ways here. Equity also would demand that access, acceptable, affordable, and appreciated care is done in all communities. And you might have heard this before. I'm a primary care fan. Primary care is a way to achieve that. But not just in words. I think primary care with true penetration into the community is where we need to do. One thing I was really impressed when I visited Bali last was my friends took me over to see some Banjars and how they were doing information dissemination. You already have a traditional model at the grassroots level. Could we tap into that as a way to improve primary care penetration into communities? That would be a wonderful model to look at, a traditional structure that is, stood the test of time with primary care approaches.
Mm-hmm.
And I know that doesn't exist in all other parts of Indonesia, but in Bali, that could be a wonderful model to look at.
Mm-hmm. Is that similar traditional structure exist in India, Prof. Sally?
There used to be. There was what's called a panchayat structure, and that was lost, and there is a recovery of the panchayat structure, but that doesn't exist when you come to bigger cities. In the local smaller towns in some parts of the country, those have functioned really well. A friend of mine did a really good thesis on the health and governance structure at the grassroots level with panchayats. And it's fascinating. In some states, they've really been well nurtured. The challenge, Dr. Suharsha, is that India is huge, right?
Yeah.
So there are some parts of India that has not grown enough.
Yeah. So another good question here, Prof. Sally, so from one of our students who just come back from Edinburgh. So I would like to invite Rena directly to ask the question to Prof. Sally.
Hi, it is an honor to talk to you directly. So I have a question. It really intrigued me as how you mentioned that is important to emphasize the context in like primary healthcare to solve inequity. For example, tackling specific or like certain diseases in different communities. But however, for quite some time, the global bodies like the big agencies has been imposing targets as mechanism to like consider the achievement of health for like certain countries. And in this case, primary care has been used as a tool to attain those targets instead of, serving what is the actual problem in those specific communities. Is there any possibilities to like combine this bottom-up approach and the top-down approach, or do we have to choose one? And if we have to choose one, which one do you think is in the top priority? Thanks.
You're right, Dr. Sutarsha. That's a wonderful question.
Yeah.
Rina, that's wonderful. My favorite answer when I teach medical students is that the answer you can give where you'll never be wrong is it depends. So I'm going to use that. But let me give you an example. A few years ago, I was talking to a gentleman from Pakistan. And the context of this conversation is based on the premise that there was still wild polio in Pakistan, and eradication of polio was an important task. From a global perspective, it is absolutely important. The challenge, however, was at the grassroots level. A lot of people in Pakistan were asking the question, we get about 3 or 4 wild polio cases a year. Every year, thousands die of diarrheal diseases in Pakistan. Many hundreds die of motor vehicle accidents. And let's not talk about terrorism and other acts. So why is it that a disease that claims 4 people, maybe, is given more importance than conditions that kill thousands? And it's a beautiful question, right? Now, from the international perspective, from the global perspective, eradication of polio, like we did for smallpox, et cetera, is a fantastic opportunity. And we need to do that. But at the grassroots level, is a death from diarrheal disease worse or less important than a death from polio? How do you measure that? And this is where I think context matters a lot, Rina. And my answer, and we do this in leadership training, is that we should not pit one against the other. The human beings have a tendency to do one versus the other a lot. Is it diarrheal diseases, polio? It's diarrheal diseases and polio. So, we talk about them being polarities. So mapping the polarities and approaching it from the viewpoint of it's not an either or, it's and approach is critical. So to answer your question from a primary care viewpoint, it's not only recognizing what those targets are that are set up by another country, but sometimes pushing back on the targets and say, this is not as important in a community because we have other conditions we need to be taking care of. So adjusting those targets to reflect the local reality is critical. This is what when I'm talking about the adaptive approach towards primary care, that's what I'm talking about. But again, wonderful question. Thank you.
I hope Prof. Sally answer your curiosity, Rena. So that's excellent question. I would like also to invite Sahara Putri to directly ask the question to Prof. Sally.
Okay, hello.
Hello.
Okay, I'm Sahara. Thanks for the insight, Professor. It's an honor for me. Talking about the post-COVID-19 pandemic, WHO announced a new variant of Omicron COVID-19, and maybe in the future we have a new variant again. On the other hand, the existence of a new normal after vaccination has caused the social responsibility to begin to decrease toward the implementation of health protocols. What strategy should we do as public health experts in responding to this condition? Thank you.
Oh yeah, this is another of those adaptive challenges. I don't think anybody in the world knows a very clear answer to that because we don't have an end game yet. What we know till now, and I'm hoping that continues with Omicron or whatever else follows Omicron, is that the new variants are still being somewhat protected. The vaccinations are still somewhat protective to these new variants. That's my hope. We saw that in Delta. Delta was really created a havoc in India and other places. But in places where the vaccination rates were high, it was still okay. In the US, we are still seeing a surge of COVID here, but the ones we're seeing in the hospital, the ones who get critically ill, are predominantly unvaccinated. So my hope is that our strategy goes back to more of the grassroots level getting more people vaccinated. Yes, there is a vaccine inequity. We don't know whether we would need new strategy. I'm always tickled when the head of Pfizer and head of Moderna say that, hey, we need new vaccination. We're like, we don't know that yet. Let's be cautious, because it shouldn't be a money-making business here for that. But I think going back to the premise of getting vaccination coverages to larger populations is the critical part.
Yep, that's a great response, Sahara. Hopefully that's answer your questions. And Kadek Trisna, do you want to ask your question directly to Prof. Sally?
Okay, yes. First, thanks for the opportunities. I want to say thanks for Prof. Sally. It's an honor for me to can get your insight here. So I have one question about your lecture today, Prof. In the holistic view presented previously, healthcare are only a small factor in global health problems, and socio-economic factors are the main problem. So how to overcome them? Because the problem is not from the health sector. Health workers do not have full power in overcoming economic problems. Then what is the solution to improve global health, whose main cause is not healthcare, but socioeconomic economics? Moreover, the economic has worsened since the COVID-19 pandemic. Thanks.
Thank you, Kadek Krishna. That is a really good question. Yeah, a couple of quick corrections. When I showed that slide, it's not just in global health, it's in all communities. At the community level, clinical care contributes only to about 10% of the improvement in health. My point there is, when I was presenting that, is also to say that social economic reasons are an important contributor to the overall health of communities. But those socioeconomic factors are determined by political considerations. So the answer to your question is, we need better policy, we need better politics, and we need better approaches. And I like to look at health in all sectors. For me, health does not mean that I'm waiting for somebody to get sick to come to me. It's what we do as a society at large. That is critical. I hope that answers your question.
Yep. I hope that's clear, Kadek Krishna. So yeah, silahkan ya teman-teman yang lain ya, my colleagues ya from Faculty of Medicine ya, Dr. Ayu, Dr. Sawitri perhaps. Sorry to put you on spot, Dr. Sawitri and Dr. Ayu.
Thank you. Maybe I'll take the time while waiting the others maybe to have the question. Yeah, I agree. This is a very challenging situation, and like you mentioned, adapted approach is important. And from what I observed during the pandemic situation, we know that the primary health care, especially the Puskesmas, the public health center, is in the center of mitigation. So, but on the other hand, they also they provide essential cares, but they also conducted the surveillance, the contact tracing, and everything. While there's also shortage of resources, distributed to primary health care. I know in the future how we can tackle the situation. I mean, right now I and Dr. Sutarsa is trying to conduct a review, collecting strategies to overcome this. But maybe you can have some thought about it. Thank you, Prof. Sally.
Dr. Ayu, that's a wonderful question. I'm going to use a word that Dr. Sutarsa used earlier: resiliency, right? We don't give enough importance to the premise of health system resiliency. What I mean by that is, when a health system is operating at its full capacity, what happens if there is a surge, and how do you create that surge capacity handling, right? In the macro level, at the big picture level, I think it's important for nations, districts, all of them to look at what does health system resilience mean. Again, this part is part of the adaptive strategy. So to give you a typical example, I was talking to a dear friend, a family doctor from Cape Town. And in that place, what they'd done was they had set up field hospitals as an in-between stage for COVID-19 patients, right? And the premise here was the flexibility that is involved in going beyond the traditional structures of large hospitals to a model that says we need another approach towards it. Now, I'm not saying that the field hospital model will work in Denpasar. I don't know. But I think asking the question from a resiliency viewpoint is critical. So to your point, while you're facing COVID-19, while you're seeing a surge, what happens to immunizations? What happens to diabetes? What happens to tuberculosis or other illnesses in the community? This is, I think, the critical part. And I don't think we as health practitioners do a good enough job to ask that question. And this, I think, is critical. There have been approaches. In the US, there is an approach which on paper looks good, but it's still a biomedical approach. It's called DMAT. DMAT is a disaster medical assistant team. It was developed as an approach towards this large scale, say after Katrina and big hurricanes, right? They would send a team working together to operationalize a field hospital and work. And the reason I'm saying this, it still goes back to the biomedical reductionism model rather than a health and healthcare model. So imagine a system which allows for some of that flexibility to be created so that there is responsiveness that occurs. Today, we know what happens before COVID. It used to be a small group from the US or another country going for a week, glorifying themselves. We call them short-term medical missions in the US. It's a $3.7 billion estimated industry. And come back and say, we delivered healthcare. No, you didn't. You went and just threw away some medications. You probably caused more damage. So understanding it at the grassroots level, what are the requirements to create the resiliency in individual setups is the critical question there.
Thank you. I think we should ask that question on upcoming research, Dr. Sutarso. What is the resilience of our
I already
system?
take note on that, Dr. Ayu. So we have additional question to ask. But Prof. Sally, so I'm interested in your presentation earlier about the right-based approach in the global health. So so I think there is also a growing appetite now looking at the intersection between human rights and health. So I just want to pick your brain on that, Prof.
Yeah, it's a beautiful point. If I were to go back in history, one of the important considerations, and the remnant of that is still here in the US, after World War II, when the Eastern Bloc was happening during the Cold War, approach towards two important parts was considered to be a communist approach, because it was very clearly mentioned in the USSR those days that the state provides health and education. We are still in the US facing that remnant. The opposition to anything to do with healthcare coverage for our community is met with resistance, as that's what the commies did. Same thing with education. We don't have universal education here. Education, higher education is extremely expensive, but healthcare particularly is not given as a human right here. So part of it is that political conversation, right? How do you change the conversation by saying that providing healthcare as a universal right to all citizens of a particular country actually decreases costs, improves communities, and by the way, significantly improves the economy? Can we make that argument, right? So that, I think, is a critical point. The second point, I think, is that sometimes when we restrict it to national boundaries, we miss the point that we are in the interconnected world. And when you have conditions like this, we are faced with a challenge that you might think that your neighborhood is safe. Well, I can tell you my neighborhood is not safe from COVID and other places, but you will still see that COVID persists in the world. So the rights-based approach is twofold. One is to getting to an understanding that health is a human right needs to be in the Constitution or in a written language. So there is an impetus to achieve that, number one. and approaching human rights from the angle that it's not just me and my neighborhood, it's the larger picture. So our denominator should be the world. That is a little more difficult for people to swallow. But that, I think, should be the approach for us from a rights-based approach towards global health.
Yeah, yeah. Thank you. So I would like to invite again, so all participants, students or colleagues, teman-teman dosen, atau mungkin saya on spot, Dr. Sawitri, silahkan dok.
Dr. Sawitri is the head of Department of Public Health and Preventive Medicine, Prof. Sally.
Hello, thank you, Starsa. Thank you, Prof. Sally. Yeah, I would like to apologize first because I'm not joined from the beginning, so I might be miss your slides, and I hope that my question is not, it's not miss the point of your presentation. Well, my question is, we see that the COVID cases in Indonesia now have a decrease, and it's also happened in Bali. But at my perspective, as an epidemiologist, I see that actually the public health activities that carried out is not optimal. For example, the test, the testing, and maybe the vaccination program. Well, in Bali, it's already high, but maybe it's not happen in Indonesia. But we see that the cases reported is decreased, and I know that it is true. So what might be explain this condition in your opinion, when you compare maybe with other countries, and this is something that could be better condition, or we should like stay alert for sometimes. What public health response do we need to maintain at this time? I think that is my question, Professor Sally. Thank you.
Dr. Savitri, that's a wonderful question. I think there might be a few factors, and I haven't studied Bali extensively. There might be a few factors that are leading you to have lower cases. Part of it might be the immunization rate, and part of it might be the due diligence that's already there. We also know that, and as an epidemiologist, you know this well, right? When you do modeling, you give a standard error. The distribution might be such that you never know exactly which way you go. So from a positive lens, let's all hope that's what's happening, right? We have a better immunized population, and hopefully our predictions have veered towards less rather than more, which is fantastic. But I would also want to caution, and I remember scenarios from around the world where people are like, yeah, we are fine, and suddenly it hits you. In the US, my state of Minnesota is one of the highest immunized states. And I can tell you, for the longest period of time, we were like, oh, we are good, this is great. And now we have some of the highest rates because there is still a significant number of unimmunized patients here. In Europe, there is a conversation about why Spain is being spared this time around compared to other parts of Western Europe. And it's a fascinating numbers, but one simple explanation in Spain has been that this overall adult population that is immunized in Spain is the highest in Europe. So maybe that's the reason. Either way, I hope it doesn't come back, but from being a little bit of a skeptic at heart, I'm like, watch out, just let's be careful. Right? So that'll be my approach to that.
Yeah. So just be cautious. That's probably the short way of looking at the situation, right. Isn't it? Yeah, just be cautious because it's so unpredictable. Yes. And that's what we have observed in the last 2 years. Anything right. Just can change in a snap. Yeah. Thank you, Prof. So I have one more question actually around the polarities that you mentioned earlier, Prof. So I'm quite intrigued with that notion. So we know that these are actually promoted by the global health actors through a vertical approach that they do for more than 2 decades. So moving forward, so what do you think is the best way to reduce this polarity in the action of the global health?
Yeah, so I think it was Rina who asked that question, and Rina, thank you for bringing that up. The key is approaches towards polarities is always about balance rather than solutions. What I mean by that is human beings generally respond better to an either-or question. You know, our brains are attuned to do that quickly. Choose this or that is an easier approach because that's how we are wired to. In polarities, the premise is to step back a second and say, it's not this, it's not that, it is this and that. So that becomes a little unclear. So going back to your question, the 2 parts of this polarities become the premise of relevance. So if the agenda is set up by somewhere else, maybe in Jakarta, maybe in ASEAN, maybe at the WHO level, are they considering the ground realities? And take Indonesia, for example. Indonesia is a humongous country. And the ground reality varies significantly from island to island, right? I mean, I don't have to tell you folks that. So if you have a policy that is, with all good intentions, meant for the whole country, you have to ask the question, is there a balance, or is there a way that that priority that has been set is now going to hit the reality on the ground, and there'll be something else that happens? And this is important from a public policy viewpoint because we know that a lot of times this is a decision based on economics, right? There is a fixed budget. And the fixed budget requires that there's a certain amount spent on roads, certain on this, certain on that. So how do you then convert that into a flexible model? You say, we don't really need new roads, we need something else here, whatever that something else is. This is a critical point, and it's a huge challenge in the premise of central planning versus a dynamic planning model. A central planning model is that it's set by some other place, and then it comes to the local community. And I'm here to tell you that I'm not saying central planning is wrong. We get a sense of that is wrong right away, right? It's not that it is wrong. So going back to the example I gave about Pakistan, it's not that the polio agenda was wrong. It's that the polio agenda is one part of the overall picture. So can we do both? Shouldn't we be doing both? And in Pakistan, it was further complicated because a lot of people are asking, why is a white man, in this case, Bill Gates, pushing this agenda? He must have something to do with this, right? So the distrust comes up more when people don't understand that the ground reality is not being addressed. So in polarities, it's the question of recognizing that, stepping back and saying, I'm not here to solve polio and diarrheal diseases or diarrheal diseases. I'm here to look at both of them and what is the best way to achieve both. So that, I think, is a critical part at the what we would call polarities mapping. There are some other practical tools. We don't have time today, but I'd love to chat with you more offline, maybe.
Yep. We'll certainly drop you an email to follow this conversation. So yes, any last burning questions from audience? So we almost hit 2 hours marks for the guest lecture. So any burning questions from the audience? So please use the time and take this opportunity.
I think there's a question in the chat.
In the chat, sorry.
And
yeah. So do you want to ask your question directly, Rena?
If that's okay, it would be nice.
That's all good. Go ahead.
Thank you. This might be particularly quite off topic, but I'm just gonna ask it anyway. So, as you said, in the U.S., there is like a historical determinant in healthcare due to pre-existing political sentiment about being anti-communist. However, big bodies such as World Trade Organizations, as you mentioned, has ever created like structural adjustment program to like help underdeveloped countries to create better healthcare and better funding for them. But then those structural adjustment programs perpetuates the countries who has received it to have austerity that in some way it is as if we ended up in like prolonging the anti-communist agenda. In some way, this has I think this has been like demonizing the idea of global health in a lot of perspective of underdeveloped countries. So the question would be, how do you think should we reconstruct the idea of global health to also redeem back like the trust and the purity of us wanting to help people instead of being, people saying that we have the ulterior agenda, like ulterior motive behind it? Thank you.
How much time do you have, Rina? Dr. Sudarsha, watch out. She's going to be a big time politician or something. She's wonderful in this conversation. This is great. Rina, I think the question you're asking is a critical one. And part of it is, I would encourage you to look up on YouTube a gentleman by name Andrew Mawende. Andrew Mawende is a Ugandan journalist who has spoken beautifully against aid. Because he talks about how aid creates dependency structures. It's a perpetuation of the dependency. So the colonialist tendencies are perpetuated in a different form. And that continues. So it's a beautiful thing for you to look at. What your question is getting to the root of is a critical point of who sets the agenda. The word that I've seen used sometimes, not often enough, in the decolonizing conversation is decolonizing and democratizing global health. So then the decision on who sets the agenda happens at the community level, at the community here, the local community level, right? So it is not, going back to what you said, a perpetuation of a model that is created somewhere else. I'm also not naive to say that all aid is bad. We know it's not. I think it's important to ask it from an ethical framework also. I'm going to, since you decided to ask a question that is slightly off topic, I'm going to take you one more off topic. One of the foremost thought leaders in development ethics is a gentleman by name Dennis Goulet. And he talked about 3 principles in development ethics. One particular one, the third principle he talks about is, what is man's relationship with nature? And I'm bringing that up here because it is a construct in which the whole premise field of development is asking that question. When I use the word development, it's about building dams, building roads, building buildings for people to live and all that. So his point is, let's step back a second and say, what is the relationship man has with nature while we are building roads and destroying nature, etc., etc. I'm bringing this up from the context of asking a bigger question. What is health? And when we get to understanding and defining it and circling it, we tend to recognize that the premise of health is multifactorial, multiple contributors in developing it. And that varies a lot in your neighborhood compared to mine. The overarching principles might be the same, but what determines them are different. So then the agenda to achieve that needs to come from you and your neighborhood rather than me in my fancy office. I don't have a fancy office, but just telling you that. I hope that answers your question.
Thank you. That's.
Yep. Yeah. Well, thank you very much, Prof. Sally. So it's It's been a wonderful 2 hours really to discuss complex issues, not easy. So we're not here to solve the world problem. So, but I think some of your ideas is really thought provoking, especially for me. And two points probably that I would like to highlight from this conversation. So the first one is the context and adaptive approach. So that's probably the most relevant way of dealing with the uncertainty of the pandemic at the moment. And the second point that mentioned and highlighted quite often by Prof. Sally is the importance of the resilience. Resilience is one of the keywords, and primary care or strengthening primary care, probably the best way to achieve health system resilience and moving forward. So, but before that, I would like to invite Prof. Sally again, perhaps to give some closing comment or closing statement, Prof.
Thank you, Dr. Sudarsha. It's been my pleasure to interact with you. And like I mentioned at the beginning, I wish I were there. I really look forward to coming there physically and interacting with all of you a little more. There is a richness at Udayana that is fantastic. There are some cultural tenets that are really close to me. I do recognize a lot of the names and I'm able to pronounce it a little better, so which is always fun for me. And I've always found that the folks at Udayana have been extremely hospitable, very inquisitive, and I commend you for that. Again, it's been my pleasure here. I look forward to further interactions. I will get in touch with Adi about what our next steps in this is. And my sincere hope is that we grow primary care and family medicine at Udayana and the rest of Indonesia. Thank you.
Thank you, Prof. Sally. So, and that's the end of the lecture. And I would like to give it back to Dr. Ayu to continue with the rest of the agenda. I give it back to you, Dr. Ayu.
Thank you, Dr. Starsa, for moderating really warm session, really insightful. Thank you so much, Prof. Sally. Like I mentioned in the beginning, this is not the first and last, so it is more to come, we hope. And maybe we can, like you said, we can directly chatting one maybe in a coming year in Bali, and we really learn a lot. I think the student is also very active, asking question and interactive. I'm really proud of that, and thank you so much that because you provoking a lot of ideas and a lot of thinking. I think after this maybe Rena will can't sleep after this and also digging more about the information that you provided. Thank you so much. I hope that you can wait like 5 more minutes. I know it's late there now. We are going to announce the 3 best questions. And also we'll ask Dr. Sawitri to conclude our today meeting after that. Okay, just wait.
Do you mind if I go on video mute for a second?
Oh yeah, sure. Oke, apakah sudah kelihatan?
Mungkin di-share ininya, Mbak, PowerPoint-nya.
Ini udah di-share, belum muncul ya?
Belum.
Wait. I don't know why it's not working when I share this. Wait a second. Share. Is it? Udah kelihatan nggak, Sud?
Masih gelap, Mbak. Yap.
Ya?
Yep.
Okay. I think it's a bit hard to choose. There's a lot of good questions from the student. Thank you so much for your participation. So, but this is the 3 lucky people that will get that one of the 3 tote bag on the picture. Congratulations to Rena Budiarta, Tarfi Aulia, and Krishna Damayanti. We will contact you and how to distribute this prize. Thank you so much. Congratulations to the 3 people here, and at this is the last and the conclusion of our meeting today, and I would like to invite Dr. Sawitri, the head of the Public Health and Preventive Medicine Department, to provide her closing remark and conclude our today's guest lecture. The time is yours, Dr. Sawitri.
Yeah, thank you, Dr. Ayu and Dr. Sutarsa, to handle this virtual lecturer very good. Again, I'm sorry that I cannot attend the presentation from Professor Sally, because I have another meeting that I have to attend. I would like to very much thank you, Professor Sally from the University of Minnesota, for your willingness to give lecturers to our students and lecturers in the Faculty of Medicine of Udayana. I understand that given the 13 hours of time difference between Indonesia and America, I believe it is already very late in US, and you are still here in this virtual lecture with us. So we really appreciate that you are willing to reduce your rest hours to share valuable knowledge with us. I believe that apart from an interesting topic, this material will be very useful for our students and also for lecturers in here. So we hope that, as you mentioned, that we will continue our collaboration, and there, beside the lecturer, there may be other activities in the field of research, or maybe another education activities that we can do together in the following years. We hope that the pandemic situation is well organized in the future. So we will have you here offline in the Faculty of Medicine. Once again, thank you very much, Professor. I hope this collaboration can be continued in the future. And stay healthy for all of us. Thank you. I will return the time back to the Dr. Ayu. Thank you, Dr. Ayu.
Thank you, Dr. Sawitri, for your closing remark. And that is concluding our today's session. Thank you so much, Prof. Sally. But I would like to invite Dr. Sri Budayanti. She's here on the meeting to say greeting, because in the beginning, sorry, Doc, we didn't get time in the beginning. Please, Dr. Sri.
Hi. Thank you, Dr. Ayu. Hello, Dr.
Hello, Dr. Sri.
Dr. Sutarsa and the other friends. Dr. Sally, thank you for your presentation. And I'm happy you can join with us as a visiting professor. Finally, you a part of us in Udayana. Thank you.
Okay, thank you, Dr. Sri. And thank you again, Prof. Sally. And I think I should get you go now because it's late there. And thank you again. And maybe in the future, please don't feel hesitated also to contact us, and I will, and maybe our colleagues will contact you. Please be ready. And thank you so much for your time today. Really much appreciated.
Absolutely. And like you folks say, Sukshma.
Suksma, Prof. Sally. So I hope to see you in person at some point. So
please
hopefully
keep in touch,
Bali.
Yeah. Yes.
Yeah.
Okay.
Okay. Yeah. Thank you.
Thank you.
Bye.
Thank you, Prof. Sally. Bye-bye.
Oke. Terima kasih semua Bapak Ibu para dosen dan adik-adik mahasiswa yang bertahan sampai siang hari ini. Tadi sampai 382 partisipan, jadi sangat apresiasi buat semua yang sudah membantu dari tim UPIX, dari HMKM, Angga dan timnya. Terima kasih banyak nih. Kita akan bertemu dan tadi sudah dikirimkan link absensi, nanti silahkan diisi. Di situ juga ada pertanyaan topik untuk next guest lecture. Jadi mudah-mudahan nanti kita bisa melihat apa dari animo para peserta guest lecture, apa yang bisa kita buat lagi ya ke depannya. Terima kasih semua, semoga semua tetap sehat. Kita akan bertemu lagi di lain kesempatan. Terima kasih Dr. Starse.
Yap, sampai ketemu.
Sukses semua.
Sukses semua.
Terima kasih Dr. Ayu.
Ya, aduh babynya nangis. Thank you Citra.
Terima kasih.
Thank you semua. Oke, meetingnya saya tutup izin. Terima kasih.
Terima kasih.